last minute 40, here we go again. It's always difficult talking about something that is sort of almost your baby, but this, what I am going to talk about, it's not really just mine anymore, and certainly Dr. Jason, as you all well know, is a huge, huge part of it, and I thank him for all his support and everything he does with what I'm going to talk about. So multidisciplinary training. I'm going to talk to you a little bit about our 15-year experience in the UK with ATTACK that, as you just heard, some of you have seen what we do with the simulation yesterday. So, first question I asked many years ago, is ATLS a dinosaur? Is it old, it's slow moving? Is it possibly extinct? Would it go as far as that? Well, 15 years ago, I was a frustrated ATLS instructor. Thank you very much. Thank you. I'll stop moving. Okay. And I believe there was a need for something different, something more maybe European-based, something less surgical for me as an anaesthetist, and something far more up-to-date and far more current and fast-moving. And this is where anaesthesia, trauma and critical care, or ATTACK, was born. And the course continues to evolve all the time, as you've seen with the pro-medicine and things like that. And it's currently the most up-to-date course that we're aware of in Europe. Fully accredited by the Royal College of Surgeons, but I'm pleased to say we're not alone. And obviously there's other new kids on the block out there. There's the European Trauma course, there's the Australian ETM course, that are all trying to address some of the deficiencies and frustrations that we've had with ATLS. But right from the very start, with ATTACK, we wanted it to be multidisciplinary. This wasn't just for doctors, this wasn't ivory tower stuff, we wanted everybody to come to the party. We manage trauma in teams, so we should train in teams. And if your course can't accommodate that, well then you need to sort out your course, because that's the problem. We have levels where police officers, firefighters, they can come and do the course at their level, but if they pass to the standard that's required, they will get full provider status, so it's not just for doctors. And traditionally in emergency services in the hospitals, there's lots of this stuff. There's lots of silo training. We all do our own little courses, even about the same subject, they're all slightly different, and we all go away and do them, and then we all expect to come together at incidents, and it's just going to be wonderful. And as you know, it often isn't. You know, we've all got great kit, great training, but when you pull it together, that's when we start to see deficiencies. And just doing the odd exercise now and again just isn't really enough. An example of, you know, great setup is Heart in the UK. It costs the UK millions of euros. Excellent paramedics, great training, great kit. But do they really think they're going to use some of these really advanced skills in the hot zone? Would it be better to take firefighters who've got the rescue skills and teach them some trauma, some slightly more advanced trauma? Or even better still, why not create a genuine multi-agency team and train them right from the start? Because on ATTACK, even in 30 hours, we can see how much you can do with a multi-agency team and how far you can take them and get them to work together. We need to pull down the silos. We need to embrace everybody that's involved with trauma care on the front line. No one should be excluded. And at the very least, as I say, we should be doing this more than sort of 6 monthly training sessions. Typical ATTACK scenario, whether it's in hospital or out of hospital, as those of you saw yesterday when we do the simulations, everybody gets involved. In this, there's 2 consultants, the heart paramedic, an AP, there's an ODP, there's a nurse, there's 2 doctors and a firefighter. All training together, all bringing their knowledge and their skills and sharing the training together. But when the Royal College came to us, they said, you know, when they were doing our accreditation, they were quite arrogant really. What can a firefighter or a paramedic possibly teach a consultant orthopedic surgeon or an intensivist? Well, when they came to see the course, they were genuinely stunned. They'd never seen such high-quality CRM, command and control, leadership, pre-hospital training. And they were stunned by that when they saw that within the groups, those individuals were teaching the doctors and teaching the others. And then when they go into the hospital, it all changes around and everyone shares the experience. But what about police officers and firefighters? They needed something as well. They're not going to get to come on ATTACK, and it's more than they really need, but they need something highly effective and relevant. And in the UK, we were very much aware of this guy, this poor chap, Stephen Lawrence, who died in 1993 on the streets of London from 2 penetrating stab wounds. And the police officers that attended him at the time, they waited for the experts to arrive, and in that 12 minutes, he died. People die on the UK streets like this every single day. And the UK first aid at work course, that was what was provided for police officers and firefighters, just was not enough. It was never designed for that. It was unsuitable, like some of the HSE signs as well. It wasn't really suitable for the purpose, it wasn't fit for purpose. It was never designed for operational firefighters and tactical firearms officers. And they needed to do more than that. And in October 2013, they put the onus onto the individual organisation to decide appropriate training. We needed something that was ideally multi-agency and would cross the surfaces seamlessly and would go from basic through to advanced. And in the northwest of England, we're now getting there with the firefighters, the police officers, the SAR guys and the co-responders all doing the same ambulance-approved training. On multi-agency training that goes from first aid level right through enhanced level medical care. And it follows the whole attack philosophy of a continuum of care, roadside through to critical care, with shared experience. I work in all these different challenging environments like many of you, but one thing is common. It's the same principles that we're applying, it's just different methods. And that's what we try and drive home in our courses, the same principles, just different methods. And it's all about keeping it simple. We don't get bogged down in anatomy and physiology and all sorts of complex stuff like that. We teach what really matters, like chest compressions. We teach the important things. We can plant the seeds of the advanced care as well. But we just get the basic core things important. What really matters, airway, bleeding, hemorrhage control, circulation preservation. That's the principle, the methods are different, and we gradually step them up. And this is how we step them up from the basic through to the advanced. As I say, the same principles running through, preserving circulation and stopping bleeding, but often, ironically, it's the pink column, the basic one, that saves most of the lives. In industry as well, they have a realisation that people die in the 8 minutes waiting for ambulances to get there. So we've now introduced FTAC, a first aid level course as well. It comes in at the bottom of our integrated package, our seamless approach. And they follow a simple algorithm. And if it all looks like Greek from you there sitting at the back, well, it is in Greek. Because we can even translate this into other languages very, very easy because it's all simple and highly focused. So what I'm trying to say to you in summary is, our training needs to be multi-agency. It needs to be seamless through from the most basic through to the most advanced. And then when we get to the real jobs, we can all work effectively as an integrated system. Thank you.